HIV organization and adapt to health reform, emerging models from the harm reduction providers. And my name is John Peller. I'm with AIDS Foundation of Chicago, and I'll be moderating today. We have Daniel Raymond from the Harm Reduction Coalition, Lisa Solberg from Point Defiance AIDS Projects and NASN in Washington State, and Cindy Clay from HIPS in Washington, D.C. And we're going to do a couple pieces of housekeeping, and then we'll get started. So we are not able to take questions live during the webinar today, but we encourage you to ask questions using the questions log. So you can send them to us, and we will go ahead and we'll be stopping at a couple points during the presentation to take questions. And you can also email them to me at jpeller@aidschicago.org. If you're having trouble hearing the audio, you can always call in using that old-fashioned device, the telephone, instead of listening over your computer. If you click on the webinar panel on the audio tab, you'll see, once you click the Use Telephone button, you'll see a phone number and access code that you can dial to access the call by phone. And, whoops, we have the question slide twice. Sorry about that. We also encourage everybody to download the slides and resources. They're at hivhealthreform.org, and they are on the first post right there where we circled on that screenshot, so you can download the slides and follow along. We encourage everybody to check out hivhealthreform.org, and we have a number of recent webinars that you can watch the recordings for and download resources. There is a lot there on healthcare reform. And so today we're going to focus on what we can learn from 3 harm reduction providers who are really out front in terms of figuring out how to adapt to healthcare reform. And while we are all facing the challenges of enrolling clients and scrambling to figure out marketplace plans and making sure networks are adequate and doing all kinds of very immediate health reform implementation work, there's also the longer-term challenge of becoming part of those new health reform networks, and particularly for organizations that have traditionally provided prevention services or pure social service agencies that are not affiliated with a healthcare provider. We really face challenges in fitting into this new world and new environment. So we're going to hear from 3 providers in the harm reduction community that have done a lot to figure this out, and we can all learn a lot from these folks. So we are going to turn things over to Daniel Raymond first from Harm Reduction Coalition. And Daniel, take it away.
Thanks so much. And thanks everyone for joining this. I've been really excited about this webinar, and it's great to see so much interest in it. So what I wanted to do is start off by talking about our experience in New York with looking for a pathway for Medicaid reimbursement for harm reduction services. And in many ways, New York is kind of either a pilot or a canary in the coal mine for how this could work and what it's going to look like. And the story is not complete. So my subtitle, Harm Reduction Meets Medicaid RomCom or Horror Flick, tries to capture some of the anxiety and ambivalence that we've gone through in the harm reduction community in New York in thinking, is this a good thing? Is this a bad thing? What are all of the implications? And I was going to try to get creative and follow through with, I don't know, Freddy Krueger, Ryan Gosling pictures, but this is not an extended metaphor. This will just be a kind of straightforward history and of where we are in the present, and hopefully give people some ideas and inspiration. Next slide, please. So basically, the place that we got to where we have this opportunity is that there's a huge transformation in New York State's Medicaid system that's currently underway. And New York has some particular kind of characteristics. So the Medicaid system in New York was perceived to be in a state of crisis. We've got over 5 million Medicaid beneficiaries, which is about a quarter of the entire New York State population. And the largest Medicaid spend, much larger than even states like California and Texas, at $54 billion a year, which had been growing at 13% annually. And while it's great that we have so much coverage, we weren't getting great value for those $54 billion. So in terms of unnecessary rehospitalizations and other health indicators, New York's Medicaid population wasn't doing that well. So we were spending a lot of money for a very fragmented system that wasn't delivering optimal care. That crisis provoked an opportunity. We had a new governor come in, Andrew Cuomo, who appointed a new Medicaid director, Jason Helgerson, with a mandate for change. Next slide. So one of the first things that Governor Cuomo did was set up a Medicaid redesign team, which was culled from a group of stakeholders across different sectors throughout the state. And they were tasked with coming up with ways to overhaul the Medicaid system to reduce costs and improve care. So one of the first pieces that got put into place is a global spending cap. So those rising trend lines for New York's Medicaid figures got kind of cut off, and the message was we cannot go over a certain amount, and so everything came under scrutiny. One of the main recommendations to come out of this process was this idea of care management for all. So through various mechanisms, including Medicaid health homes, patient-centered medical homes, accountable care organizations, and other tools, it was felt that care management, care coordination would be critical to improve health outcomes and control costs. One component of the Medicaid redesign team that's most relevant for us was the Health Disparities Working Group. And so part of the thinking was we don't just want to cut spending. If we're really going to get costs under control, we have to look at the drivers of costs. So things like expensive and avoidable things like emergency department utilization, hospital admissions and stuff. Are there investments that we can make that could improve care and reduce these distant health spending drivers? So Charles King from Housing Works, who many of you know, was one of the members of the Health Disparities Working Group of the Medicaid redesign team, and that group came up with a number of recommendations, including the one that we're going to focus on this webinar, harm reduction, as well as a parallel one on hepatitis C. There were a number of other recommendations that came out in terms of things like investing in housing to reduce healthcare expenditures that have the potential to be very innovative. Next slide. So this is a synopsis of the harm reduction proposal. That basically, there were three components. The one that we're going to talk about today is that state-authorized syringe exchange programs would have a mechanism to be reimbursed by the state Medicaid system. And these are primarily community-based programs. Some of them are attached to larger organizations with clinical structures, but these are really often organizations that are part of an aid service organization or started up as grassroots syringe exchange programs. And so this was very new to us. Next slide. So this was part of dozens of proposals from the Medicaid redesign team that were adopted. They were included in the governor's budget and passed and approved by the state legislature in 2012. The requirement was that you could implement this third-party reimbursement mechanism for Medicaid dollars going to harm reduction services as long as there was a federal match. So as you might know, Medicaid is a federal-state partnership where the federal government kicks in some of the dollars, the state kicks in the rest. It's roughly 50-50 in most places. So whatever the state came up with for a reimbursement mechanism for harm reduction services had to qualify for federal matching funds. So the health department began the process of getting federal approval by developing what's called a state plan amendment, or a SPA, and that process is still underway. What that means is that the state develops a mechanism that gets submitted to CMS, the Centers for Medicaid Medicare Services, and CMS reviews it. They may come back with questions or ask for modifications. Once that gets approved, then the state can integrate harm reduction services into its Medicaid program. And state Medicaid programs put together SPAs for all kinds of things. Next slide, please. Okay, so part of the process was figuring out what will Medicaid actually pay for. Because of the federal funding ban, syringes themselves were off the table, but there's a whole range of services that harm reduction providers said, this is what we do. This is what harm reduction looks like in our program and our organization. And these were adapted and translated into language that, that reflects how Medicaid works. So here's a sample of the services. Next slide, please. Here's the remainder. And they tried to kind of track closely to what programs were already doing. The state asked programs for input and what should be there and what it should look like. Next slide. So, and then the question was, so who can provide these services? And there was a bit of a tension here because in theory we want everybody to do harm reduction. In reality, we don't necessarily trust that, say, a hospital or other kinds of systems that are traditionally not always that harm reduction grounded or friendly to people who use drugs would actually be able to deliver something that looks and feels like harm reduction and gets the same results. So the state came up with these initial qualifications that they were looking for programs. In New York State, the state regulates and authorizes programs to conduct syringe exchange. You have to apply and demonstrate certain things, and then you get a syringe exchange waiver. So there's, I think, 16, 17 programs across the state with syringe exchange waivers, and then they were looking for a track record. Next slide, please. And then this was a big question. This is, you know, don't focus on the details. This is just a kind of very quick tour through what it means to develop one of these state plan amendments. So parallel to identifying the covered services, each covered service had to have some standards. So different criteria about what does it mean to provide, you know, this element of care coordination or crisis intervention. How do you document it? Is this something that can be done in 15 minutes? Does it take an hour? And then best practice recommendations. Next slide. And so the big question, which is still unresolved, is how will programs get paid for this? And that question has two components. One, literally, how will programs get paid for this? Is this going to be fee for service, or is this going to be a different model so that it's not so much each outreach encounter or each intake or needs assessment has a fixed fee associated with it, or is it going to be some kind of base or bundled payment mechanism? And we're actually having a meeting on Friday to kind of hash out what that would look like. And then the second part of the question is, and how much will programs get reimbursed? And programs are having to think about what's the cost of providing these services, what's a reasonable reimbursement rate that would include some things like admin and stuff like that, because the fear is that if the final rates are too low, then there won't be sufficient return on investment for programs to actually utilize this reimbursement mechanism. So, and this is a struggle because both these are new services. Some of them mirror some other things that Medicaid currently reimburses for in different contexts, but some of them are relatively new. And most of these programs don't have experience with Medicaid billing, so it's harder for them to kind of crosswalk and anticipate what the rates will look like. Next slide. So this has been a whole process going on for at least a year and a half, really closer to 2 years from when it was originally conceived. And so it's involved a lot of meetings and calls between the health department, and in this case, it's been spearheaded by the AIDS Institute, which is the part of the state health department that oversees all the AIDS programs, as well as some related initiatives like hepatitis C. So the harm reduction programs have been meeting regularly and doing calls with the health department. The health department provided us, the Harm Reduction Coalition, with a little bit of money to do needs assessment with the programs on their level of readiness for Medicaid reimbursement. So we brought in a consultant who pulled programs about their billing and finance systems, some of their health IT infrastructure and capacity, and then translated that, because we found not unexpectedly a lot of needs and a variety of places where people were on the spectrum, into some technical assistance. And we've done a couple of trainings on what the billing cycle looks like, and things like what you need in terms of staffing in your finance or back office in order to make billing viable. But we anticipate that the TA needs will be ongoing. We also needed to kind of get our own handle on what this really should look like. So we've had a very productive engagement with the state health department and a lot of good back and forth, but we also wanted an independent analysis. So Vocal, which is an organization that many of you know, secured pro bono assistance from a law firm, Ropes and Gray, that worked with us to develop an analysis and make recommendations for what the state plan amendment should look like, and for how this should be implemented overall, how it would interact with other components of Medicaid redesign. And that was incredibly helpful to have that external perspective. And then we've also benefited from having a mechanism for ongoing coalition discussions, and we've developed an implementation working group. This is through IDUHA, which is the Injection Drug User Health Alliance, which is a coalition that we formed about 10 years ago of all the harm reduction providers in New York City. Next slide. So that's a quick run through, and I'd be happy to provide more details and more information. Basically, the elements of the state plan amendment that I've talked about are still under consideration. Right now, the draft state plan amendment is sitting at the Office of Health Insurance Programs at the state level, and in preparation for final submission at some point to CMS. So we could have a yes from the feds anytime from, say, 4 or 5 months to a little over a year from now. So we're in a bit of a waiting period, and then we're going to be working out some of the nuts and bolts in terms of reimbursement. Along the way, we've come up against some challenges, and I tried to put in some notes about how we've been responding to those challenges. So the first thing, and I have to admit, when Charles King first pitched this idea to us, I was very resistant. I said, I don't know how this is going to work. We have a culture in our programs of low-threshold services, heavily dependent on outreach, the role of peers, and in particular, an expectation of anonymity amongst people who are coming for services to us, at least the low-threshold ones. That has been the dominant culture of syringe exchange and, by extension, harm reduction programs, that due to stigma, fear of law enforcement, and so forth, that our programs had a kind of baseline expectation of anonymity. How does that interact with Medicaid reimbursement? And the question of how these services are going to be structured. Are they going to become higher threshold, more regimented, more kind of uniform, sort of assembly line? That kind of goes against the grain of meeting people where they're at and the fluidity of how programs develop their own culture of harm reduction in response to the needs of the particular participants that they're seeing. The role of peers and non-clinical staff, that was a big fear. Is Medicaid billing and reimbursement going to require professionalization? So a lot of programs have a strong place for peer work, as well as hiring staff positions from people with substance use experience and history of their own who don't necessarily have a social work degree or clinical credentials. We think that because of the support from the State AIDS Institute, we're going to be able to navigate that, but that is an ongoing uncertainty. Infrastructure and capacity in terms of billing, record keeping, compliance, these are all things that are, for most programs, going to be needed to be added on to their existing systems. And that requires a significant investment. We're working to identify potential funding sources to help programs make that investment, but especially as we don't quite know how the actual payment is going to work out, what's the return on that investment? How are programs going to be able to calculate is it worth it for me to go in this direction, or am I going to sink a lot of costs in developing this infrastructure and at the end of the day not get a whole lot out of it? And then finally, in New York, as in many, many other states, we're moving towards a managed care environment, whereas a lot of things were fee-for-service and carve-outs. Just about everything is moving under managed care. So it's one thing to try to be negotiating and hashing this out with the state, with the health department and the state Medicaid director. Eventually, we're going to be able to figure out how to negotiate directly with managed care organizations, which will be less familiar with harm reduction, have their own kind of profit motive in terms of controlling costs. And one of the ways that we're trying to navigate that is we're exploring establishing what's called an independent practice association, which would allow programs to band together and strengthen our hand in negotiations with managed care organizations. Next slide. So we've had a number of assets that have helped us. We've had great leadership and support from New York State Health Department States Institute and a strong history of relationships and collaboration between state and programs. We have a well-established coalition which has a part-time coordinator that's helped us move forward with a lot of these projects. And some of the harm reduction providers had some preliminary experience with Medicaid health homes in HIV case management's transition under that umbrella in New York. And that experience has been sobering. It's had its ups and downs, but it's given at least some programs a bit of a vantage point and a foot in the door in the world of Medicaid. And then we've had the benefit of advice and feedback from a much broader network, both on the HIV side and people working in behavioral health in terms of understanding the kind of learning curve around what these transformations look like. Next slide, please. So I wanted to give some key lessons. The first for harm reduction providers is define your niche and your value. And I can talk more about this, but the best thing about some of these transformations that are happening with Medicaid and more broadly healthcare reform is that the things that we're good at in terms of engaging and retaining people with substance use histories who are marginalized from the healthcare system have become incredibly valuable. New payment models put a premium on making sure that this population, the behavioral health population, which is seen as a driver of costs and high utilization, has more stable coverage and engagement and linkage to care. If we can translate what we do well in that field to what's of value to different payers in the healthcare system, then we have something to package. Second lesson, talk to everyone. This was never an expertise of mine. I found that people were really happy to help mentor and guide me and give me feedback in my own learning curve. Data gives you leverage. The more that you can document about the outcomes for the services that you're providing, the more convincing your case when you talk to different potential partners. Strategy and leadership, I think Cindy and Lisa are going to talk more about that. But one final lesson, don't get paralyzed. Don't wait until you've learned everything that you need to know or that you think you need to know about healthcare reform, because you're never going to get there. So act now and keep learning. But it really is about not getting paralyzed. Next slide. And so I'm just going to make a very quick pitch that we're looking to support other harm reduction organizations that are doing this kind of strategic thinking. I'll send out more information, or John will send out more information in the follow-up, but feel free to reach out to me. Last slide is a few additional resources. And the white paper that the pro bono law firm developed is on the website of IDUHA. Thank you.
Great, thank you so much, Daniel. We actually don't have any questions from the audience at this moment. Actually, we do. So the question is, are documentation procedures going to change for agencies? And I would presume that that's requirements for documenting services provided.
Yeah, the answer to that is yes. We're not entirely sure how right now. It's partly tied into the question of reimbursement. So What reimbursement looks like will determine what documentation is necessary for reimbursement. And then the other part is that there's an interest amongst the programs in setting up health IT electronic health records. And I think that we would have moved in that direction anyways, just because our current monitoring and documentation systems are very much grant-driven. So we document what our programs are paid to do in terms of outreach contacts, syringes distributed, but those aren't very helpful in documenting long-term outcomes or utilization patterns. So yeah, that is a big part of the conversation, and I think that's going to be a big part of the work for us over the next years in figuring those things out.
Daniel, could you talk about how you've documented outcomes? We here at the AIDS Foundation of Chicago are going through a very similar process where we're trying to, figure out what services might be reimbursable. And, we've really been paid by our funders to count widgets, and counting widgets does not result in outcomes. So how have you been able to get those outcomes that have been compelling?
Yeah, it's been really challenging. I think that we've spent a long time in the syringe exchange field in New York and elsewhere and saying, look, our HIV rates among people who inject are down. That means that what we're doing is working. It's that middle part about which kind of ingredients and what sort of dose is working. Does it work for everybody equally? We know that we still have some disparities in terms of who's getting newly infected and diagnosed. So we have a couple of programs that, including Boom Health and Washington Heights Corner Project, that have kind of taken up this challenge by doing sort of snapshot surveys of their participants where they ask about things like, has your needle sharing gone down? Are you going to the emergency department fewer times? Are you better linked up with primary care? And we're working on rolling out an IDUHA-wide initiative to expand that survey process itself. That's one mechanism. I think the trade-off for low-threshold programs, especially anonymous programs, is how do you track these kind of outcomes over time? And I think that we need to depend on the goodwill and engagement of our participants to help us out with that. And so that's why we're using a kind of longitudinal survey methodology.
Great. Thank you, Daniel. That's very helpful. We are now going to